Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Mass Maker sessions. We are currently in our nephrology modules and we will be running through some questions with you guys. And uh, this video is all about congenital kidney diseases and cysts. So, which of the following clinical feature is most commonly associated with autosomal dominant polycystic kidney disease? Now, I have kept this question because whenever you read the last one first, you may not even have to read the rest of the question listing. And that's what we are going to do here now. So, which of the following is the most commonly associated with ADPKD? Uncontrolled weight loss, hematuria, hypertension, oliguria, or headache? So, hematuria, blood in the urine, is a common clinical feature associated with autosomal dominant polycystic kidney disease. The presence of renal cyst can lead to bleeding, resulting in hematuria. And this hematuria may be microscopic or macroscopic and can contribute to recurrent UTIs. Other options include uncontrollable weight loss. So uncontrolled weight loss is not a typical clinical feature of ADPKD. Hypertension, so elevated blood pressure, not hypertension, is commonly associated with ADPKD. Hypertension is a significant complication of the disease, not hypotension. So while impaired kidney function in ADPKD can lead to decreased urine output, oliguria is not a characteristic clinical feature in the early stages. While hypertension associated with ADPKD can cause headaches, it is not the most specific or common clinical features. So let's review the first part of the cystic kidney diseases. So autosomal, it is in the name autosomal. So there are numerous cysts in the cortex and medulla causing bilateral enlarged kidneys or ultimately destroy the kidney parenchyma. It presents with combination of flank pain, hematuria, hypertension, urinary infection, and progressive renal failure. The mutations in genes including polycystin protein, PKD1 or PKD2, is involved in case of autosomal dominant polycystic kidney disease patient. The complications include chronic kidney disease and hypertension, which is due to the increased renin production. Now, this cause of hypertension due to the increased renin production is very commonly asked in the examination. It may be associated with aneurysm, mitral valve prolapse, benign hepatic cyst, and diverticular cysts. Now, these associations are also very commonly asked in the examination. Treatment. So if hypertension or proteinuria develops, we need to treat with ACE inhibitors or angiotensin receptor blockers. Similarly, there is another form which is called as the autosomal recessive polycystic kidney disease, where there is mutation in the PKSD1, including fibrocystin. There is cystic dilation of collecting ducts, often presents with infancy and may be seen on prenatal ultrasound. It is associated with congenital hepatic fibrosis. And there is significant oliguric renal failure in utero, which can lead to Porter sequence. It concerns beyond the neonatal period include systemic hypertension, progressive renal insufficiency, and one thing important is the portal hypertension and congenital hepatic fibrosis. In ARPKD, if they have to test any one concept, they will test you about the cystic dilation of collecting ducts. The autosomal dominant tubulointerstitial kidney disease, which is also called as the medullary cystic kidney disease, it causes the tubulointerstitial fibrosis and progressed renal insufficiency with inability to concentrate the urine. Medullary cysts usually are not visualized, and there is the small kidneys are present in the ultrasound. It generally have a very poor prognosis. Simple versus complex renal cyst. So simple cysts are filled with ultrafiltrate, very common and account for majority of all renal masses, found incidentally and typically asymptomatic. Complex cysts, including those that are septated, enhanced, or have solid components on imaging, you can follow up or removal due to possibility of renal cell carcinoma. And then we have one more question here. Which of the following anatomical characteristic is characteristic of horseshoe kidney? Anterior positioning of the kidneys, fusion at the upper poles, normal ascent during embryonic development, posterior positioning of the kidneys, absence of ureter. So fusion at the upper poles. So horseshoe kidney is characterized by fusion of the lower pole. Okay, so this is lower pole. Okay, fusion at the lower pole, and it gets trapped in an artery. Okay, so this is lower pole. Sorry for that. So fusion at the lower pole is a characteristic of the horseshoe kidney disease, and instead of the typical ascent of the kidneys, the fusion occurs at the lower poles, creating a U-shaped or horseshoe-shaped kidneys. So again, the inferior poles of both kidneys fuse abnormally, and as they ascend from the pelvis during the fetal development, the horseshoe kidneys get trapped under inferior mesenteric artery and remain low in the abdomen. The kidneys can function normally, but associated with hydronephrosis. renal stones, infection, or there is increased risk of renal cancer. In horseshoe kidney disease, if they want to test two concepts or three concepts, that will be number one, the fusion of the lower pole gets trapped under the inferior mesenteric artery. Number one concept. Number two concept, there is increased risk of UTI. Number two, and number three, it is associated with Turner syndrome or trisomies 13, 18, and 21. Horseshoe kidney disease, only three concepts are testable, and if they want to test on horseshoe kidney, they will test you on these three concepts. Now, which of the following congenital anomalies is suggested by the VCUZ findings in this patient? A newborn male is brought to the pediatric urology clinic due to a history of poor urinary stream and recurrent urinary tract infections. On examination, the child appears well nourished and abdominal examination is unremarkable. During the voiding cystourethrogram, there is evidence of dilatation of the posterior urethra and constant material reflux into the dilated ureter. Which of the following congenital anomalies is suggested by the VCUZ finding in this newborn? Vesicoureteral reflux, hydronephrosis, posterior urethral valve, ureteropelvic junction obstruction, or ureterocele. So the VCUZ findings of dilatation of the posterior urethra and reflux of contrast material into the dilated ureters are indicative of posterior urethral valve. PUV is a congenital anomaly in which there are abnormal obstructing urethral folds in the posterior urethra, leading to urinary outflow obstruction. So again, PUV, the membrane remnant in the posterior urethra in the males, its persistence can lead to urethral obstruction. It is diagnosed prenatally by bilateral hydronephrosis and dilated or thick walled bladder on ultrasound. There is severe obstruction in fetus associated with oligohydramnios, and the most common cause of bladder obstruction in male infant is PUV. In PUV, if they ask you about the concept, they will typically ask you that the patient is having this reflux sort of thing, and what may be the most common cause of this symptom. So the most common cause is PUV. So talking about the vesicoureteral reflux, which is the retrograde flow of urine from bladder towards upper urinary tract, can be primarily due to the abnormal or insufficient insertion of the ureter within the vesicular wall or the ureterovesical junction, or secondary due to abnormally high bladder pressure resulting in the retrograde flow by the UVJ. There is increased risk of recurrent UTIs. So if they want to test you about the vesicoureteral reflux, they will test you on the increased risk of recurrent UTIs in the patient. Thank you for watching. Keep studying hard.